So 2 years ago, this paper has been published that has been the fruit of hard work, because there have, you see as the authors, 4 clinicians with experience with thalassemia and 8 top-level cardiologists. So has not been easy, in my experience, to work with, and Renzo Galanello too. We were, and also John Porter, we were not, Alan Cohen was just the reference, but we worked at that. But has been interesting because it has been fruitful, and also for the cardiologists. Some of them say, oh, it has been interesting. So you see this paper is close to 30 pages. I don't tell you about the methodology. That is very hard because the American Heart Association, for guidelines or consensus paper, has a very strong methodology, very hard to be. Anyway, I will present some summary from these, just simply the text, but with some comment, and putting in red what is relevant to us. For the diagnosis of heart failure in thalassemia major, you know everything that is standard, but possibly we have to focus on this, that the diagnosis may be difficult in many cases. It's not rare to have difficulties with diagnosis. In example, liver congestion with abdominal or back pain and nausea, with some dizziness and presyncope, may be the prevalent symptomatology. So with nothing evident, the classical heart failure. So this may be a trouble for us, but also for cardiologists too. So we have to, and the classical signs may appear late. This is a paper published several years ago where our Italian colleague looked at 6 patients that died from congestive heart failure. And if you look, severe iron overload, hepatic enzyme, but look at this. At first head diagnosis in the emergency, so nobody, no doctor dealing with thalassemia, this strange, you see? Acute abdomen. And you see how many days from first evaluation to death? So it's not easy in many cases to have the right and early diagnosis and to treat properly. That is a point. Then cardiac iron and T2 star, you know everything. So cardiac T2 star, severe level predicts heart failure and blah, 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 we know. Left ejection fraction is different because we underline that also falling left ventricular ejection fraction values, even in the normal range, but falling. If you have 2 or 3 values that are slowly falling down with the patient that is well, be careful. That is the message. And then the left ventricular ejection fraction going to pathological level, falling, may be a late event. So it's too late. This may be very important. And so, obviously, the practical advice is to chelate or to change the chelation treatment and to intensify the chelation in these cases. Then what was fascinating with the cardiologists, and they insisted so much, is, okay, this cardiomyopathy from iron toxicity, chronic iron toxicity, is reversible. And this is very strange because most, if not all, the cardiomyopathies are not reversible. It's true that some of them are genetics, most of them are genetics, or fruit of a chronic disease with another physiopathology, but it's rare to have partial reversibility or full reversibility is impossible. With the iron is not, so that is. And this is just one example from my series where you see what? A patient that was on Desferal with ferritin lowering, high, but not so high, lowering, and the liver iron concentration also lowering, not so high and lowering, but you see the left ventricular ejection fraction that was, let's say, not in the normal range, but lowering. It was impossible in the past to insist with this patient. We tried to convince this patient to have intensive chelation, impossible. Was very conservative, say, no, I'm taking Desferal since birth, I want to continue full stop. Don't worry me. The first time we had the chance, you see this period, to have a cardiac T2 star, the cardiac T2 star was very low. So, but again, the patient was not convinced to change treatment. And after a short time, what happened was this, that you see acute heart failure. So ejection fraction dropping down. So the patient was close to die. Admitted to the hospital, intensive treatment, intensive chelation, so continuous chelation, etc. What happened? Obviously, we use a Desferal and the ferripron. What happened? Look at the difference of the ejection fraction with a very fast recovery to normal level. And then you see also this is interesting. Look at this. That is a clear trend to rise, very, very slow, a clear trend to rise. That this is interesting too to us. But look at the cardiac iron. Very slow, more than 2.5 years to reach from this level to reach to be above 20. That was what we were talking about. Iron toxicity and a cardiac iron load. Very, very different things. So, cardiac iron and cardiomyopathy and heart failure may be reversible. In other patients, it's not so. In the past, we had patients that even with intensive chelation died after the acute heart failure. So what is this? This effect, in our mind, this effect is the mitochondrial dysfunction here that was borderline, and then for some acute event precipitated, and the recovery of mitochondrial function in the myocyte, getting out the iron with the intensive chelation and using the ferripron. Obviously, the ferripron must be in. Thanks to have used this case in Vasily Berdukas and published recently a very nice review on this, and they put this in the paper. I thank you very much. So, let's continue. Treatment of acute decompensated heart failure with reduced heart failure. Where should patient be treated? Many details. A key point is this. Again, as we were discussing this morning, and also Merula was saying before us, integrated between a specialist and who is treating thalassemia. That is key. And then today the cardiologists, the top cardiologists are saying this. It's let's have the patient surviving if there is an acute decompensation to be alive, and let's have the time for iron chelation to detoxify the cardiac iron. So they are less and less intrusive with the cardiological treatment during these acute phases, because what is important is this is key. So to start with continuous chelation and intravenous Desferal at this dosage, not more. You know that higher doses may cause acute toxicity, may worsen the hypotension that is a characteristic of this type of decompensation in anemic patients that do have hypotension also when they stay well. Then what else? To add the ferripron as soon as possible. Why, if we have intravenous Desferal, 50 milligrams, 24 hours, why to add another chelator? Because this chelator has peculiar characteristic to clear very fast the cellular iron with the standard dose. And so, again, you see, avoid aggressive inotropic therapy. This is key too. What else? Many, many other details, but these are details, but in individual patient may be important. Hydrocortisone, why to give small doses of hydrocortisone? What is the need to give cortisone in this condition? Again, we know that in thalassemia and in iron load and in chronic toxicity from iron, you have an adrenal insufficiency, not for standard condition, where you measure cortisol in standard condition, normal in thalassemia. But the response of cortisol to stress, and this is a big stress, as infection and other condition, is abnormal. So to give may be useful or may be key in some patients. So we should have in mind. Hemoglobin higher, obviously, search for a precipitating condition of this acute event, obvious, and other details that is to look for hypoparathyroidism or hypothyroidism, even if there are conditions that are not so serious during heart failure, may be very important if you correct and if you normalize. We said about adrenal insufficiency. The same for hypogonadism, because in this condition, it may be very important to correct, because the action of the sexual hormone in sustaining the cardiovascular system is very important in stress condition. And the same from growth hormone deficiency. If you don't search for growth hormone deficiency in adult patient with thalassemia, you don't find, because you don't have the classical form. And maybe that you find in this condition that is late, but is important to find and to correct in the case. If the patient has an abnormal glucose tolerance, it's important to try to have a during these days that are critical for survival. And the same is for other aspects, the thiamine, B6, folate, carnitine also, and vitamin E, obviously. And then, when the patient is starting to recovery, what to do and when to convert from intravenous to subcutaneous deferoxamine, and to have the patient as an out patient instead of continue to have the patient. It depends on the individual basis. What is key, and our recommendation, is to continue the 24 hours treatment with Desferal, and is possible with modern infuser to have these also subcutaneously. And let's say, so let's change and see a less serious condition, that is the treatment when there is no cardiac decompensation, when the patient is well. The level of urgency, we put some think about, obviously, the level of cardiac iron. If the cardiac iron is less than 6 milliseconds, similar to what we discussed. If is between 6 and 10, maybe, or maybe, we recommend to intensify, but not necessarily at the maximum level. Between 10 and 20, be more conservative, may be the right general advice. And this is obvious. Let's go on. What else? to look at, in this condition, to look and to monitor other preclinical markers of cardiac iron toxicity. In example, in patients that do have, stay well, but high ferritin, high liver iron concentration, let's say low or inadequate compliance with chelation, and where it's difficult also to know if the patient is chelating something or stopped completely the chelation. It's to look at the very simple electrocardiogram and to look at certain, obviously, arrhythmias, but also these QT prolongation and maybe exercise capacity if you do, but also with the simple ECG, if you go, and there are a couple of papers on this, in thalassemia, if you go and look for, this is for your group, no? If you look, we had the same experience, not exactly the same, but if you look for, oh, there was some arrow here underlying that for some, all of these are aspecific, okay? But if you have a patient with thalassemia and iron overload, where you see these non-specific wave change, STT wave changes, or QT prolongation with T waves abnormalities, and a trend to bradycardia that was not present before, you are sure that your patient do have important iron toxicity, and you are sure that the patient is not chelating at all, not is chelating one day yes, one day no, is not chelating at all, stopped chelation. So we use this also for the interaction with the patient. It is say, oh, listen, conversation, yes, but listen, this is your ECG. Look at this. You have direct iron toxicity. You are not chelating. This is the fact that are telling us. So let's discuss and let's see what to do. What about the liver iron? You know the story, but it may be that if the liver iron is very high, is preventing the full efficacy of any type of detoxification, no, but the iron chelation you are doing. So it's very important to have this in mind. You know the story, and again, John Wood has been the first to focus on this, that the trend of iron loading is not linear, but we have a trend of the liver to load same in the other tissue, including the cardiac iron. And then when the system is close to be saturated, you may have a fast loading through ion channels, a fast loading of certain type of tissue and cell, like the cardiomyocyte and endocrine cells. And the same, the opposite you have when you chelate efficiency. You may need so many months or many years to lower the liver iron before having some or interesting result in other tissue, starting with the heart. So this is very important. It's very important for the patient to have in mind this. An example of loading in peculiar condition are pregnancy in thalassemia, or in other condition where there is an abnormal erythropoiesis and not efficient erythropoiesis. You see, these are our pregnancy, the first one that we put together. Our patient where there has been in all of these an interruption of chelation for at least 5 months, but in most 9 months. What happened, you see the cardiac iron loading going up. In some patient with the liver iron, you see that at start of pregnancy, the liver iron was relatively low or very low. But the same we had the cardiac iron loading. So this is thalassemia, obviously, is not normal. Then, so what's about the cardiac iron chelation strategies? If there is myocardial iron overload without cardiac decompensation, the three chelators, all of them remove cardiac iron. This is very true, but they are very different. So optimal therapy must be tailored for each patient. There is no chelator that is better than the other in general, but must be tailored. How be tailored? As regards deferoxamine monotherapy, you know everything. In this condition, we recommend to increase the duration. The days, if the days are not 7 days a week, obviously, because to have myocardial iron and to prescribe 6 days a week or 5 days a week, it's, sorry to say, it's a shame. But also for the patient, it's important to know very well, so days and also duration, not to cover 7 hours a day with this condition, having the toxicity going on, even if the compensation is not in. The ferriprone is superior, full stop. So for any condition where you are searching cardiac protection, the ferriprone alone or not must be in. But in most cases, in monotherapy, it's enough. And we recommend also, based on the papers that has been published, that higher dose than 75% may be very useful and not related to less tolerability. Yes, this is the summary of this. And what about the Ferrazirox? In the paper, the Ferrazirox cleared the cardiac iron, but with the same trend of deferoxamine, that is interesting but not enough. So it's comparable as a trend, as the velocity, the speed to deferoxamine, again with no change in left ventricular ejection fraction. Being this not relevant, and some of us is saying if the left ventricular ejection fraction is normal, no relevance in changing and improving this. My opinion, and many of you, is that is relevant to increase a left ventricular, a normal or supposed normal left ventricular ejection fraction in this condition, because it's clearing and lowering the iron toxicity in the mitochondria. There are on the Ferrazirox also, the sponsor studies, like the Cordelia, the very large Cordelia studies. I had a function in this, a very large, very potent one, confirmed this, that is. So, the Ferrazirox, it's okay, but is, equivalent to deferoxamine. It's better than deferoxamine from the practical point of view, but is equivalent. And also in small but more selective studies, like this one that we did in Italy and we published last year on using the Ferrazirox as monotherapy for cardiac siderosis, we saw the slide is very boring, but we saw the same, that is similar to deferoxamine, no change or poor changes in left ventricular ejection fraction and other functional markers of cardiac. So, at the end of the day, for the Ferrazirox, for myocardial iron without cardiac decompensation, we recommend to use caution in deciding what to do, mainly when the patient do have high liver iron, because today is clear that when the Ferrazirox is efficient for liver iron, but if the liver iron is high, the effect, the general effect of the Ferrazirox in the patient in other tissue is relatively poor or very poor. Combination. Again, many words in summarizing the evidence in the published paper and blah, blah, blah. At the end of the day, combination of deferoxamine and deferipron using especially in patients with moderate to severe cardiac iron overload and or when the left ventricular ejection fraction is impaired. Same story. This is the first, yes, thanks, I will. Future direction, because there has been a lot of hopes on new chelators and a lot of interest in the trials combining, in example, other combination and combining the deferoxamine and the ferraziroc. We wrote these closing and publishing the paper. So what happened? What is the update from this point 2 years ago and now? Very, very poor, very, very poor, because for new chelators, the best that was entering the phase 3, that was this oral chelator failed. So you have just one paper in the literature. We are waiting to publish the second, the trials we did, but due to more to safety reason that because the efficacy was interesting. Some of my patients that had for years this chelator saying, why is not I'm not allowed to continue? It was very effective, but for important safety reason, failed completely. And for this type of combination, the ferrazirox and the deferoxamine, a few weeks ago has been published the trial on this combination, a large trial, and I was very excited to read the result, but this result again has been really a delusion, because you have now in the literature, you can read, this is the result. You see, was a combination of full doses of the ferrazirox with full doses of deferoxamine every day, not partial combination. And you see that the effect on the, you see the cardiac iron, the T2 star, geometric mean of T2 star, that you see that it rose up, but very slowly. You see, these are 2 years. And this is the number of patients. So you can guess that the patients that are not here, that went out, and went out for safety reasons, some of them for safety reasons, and we cannot say, but some of them went out for low efficacy. So the true, in the clinical setting, the result of this, we can guess, will be something lower than this. And the same also for the liver iron. The authors clearly tried to see if the liver iron concentration was important in determining this type of result and dividing the patient. But you see the patient more than 30 or less than 30, so we are talking about very high level. And you see that there is some difference, but the trend is very poor. This is interesting to me because the last result in this is you have the patient that went to the end of the study and the intention to treat. In gray, you have the intention to treat. And you see that with the intention to treat, this result, that is the proportion of patients with T2 star more than 10, they started with less than 10, all of them, was the inclusion criteria. More than 10, or a rise that was more than 10% from baseline was also at the end, to me, a delusion, unfortunately. In the publication today, what is happening is this, that if you read only the title and the key point, you read this, that is true, it's not false, but it's something different from the true facts that are in this paper. That is, so this is our recommendation for cardiac iron overload, mostly based on opinion and experience, because you know better than me that the scientific evidence in this, and mainly for heart failure, but also for most of the cardiac iron are not controlled studies, etc., etc. Anyway, this was the best we were able to do. Thanks.
Did they say anything about ejection fraction in the last study? The Novartis?
I didn't check. I didn't read. I don't want to answer in the. I didn't see nothing special, but I didn't check.
Nesse consenso, não foi mencionado a questão de combinar o quelante oral deferiprona mais o deferazirox. Mas eu gostaria que você falasse um pouco da experiência, se você tem experiência em combinar os dois quelantes orais, principalmente em relação à questão da sobrecarga de ferro cardíaca.
We didn't write anything special in this consensus because lack of papers published at that time, and our experience, we had some experience at that time, the four of us, the clinician, but was too small to have some consensus to write. Obviously, there are very interesting things on that, but at the time and also today, we cannot discuss, it's very interesting, but we cannot just say and recommend.
Seems like it was crystal clear.
They are,
Dr. Thomas.
They are tired.
Well, maybe I just make one comment. And you know, our medical practice is often dramatically changed personally by one single patient, like the one that you presented, and that patient is terrific, the one that went into heart failure very suddenly and came out. And you made a comment about not giving Desferal 5 days a week or 7 days a week or something. One of our very first patients back in 2003 that John and I managed was a PhD pharmacist with thalassemia. And she was on Desferal, and she took it 24/7 from Friday until Monday, and then not the rest of the week. And her liver iron was 5, and her ejection fraction was mildly decreased, and her T2 star was 15. The only thing we did is change her to 7 days a week Desferal. We did not change her total weekly dose. And she cleared her heart and corrected her ejection fraction. So I think that, I mean, this is an N of 1. It's hard to do statistics. But I think this point of having something around all the time, I mean, we tell our patients if you stop your chelator during that 1 day or 2 days, you're right away reloading your heart. So I think these combinations are probably pretty important, and especially the long-acting combinations like deferasirox plus deferoprone.
I don't have in mind from my serious case is so clear as this one, but I have in mind, in my experience, that having daily chelation is giving important result. It's very difficult from the practical point of view to convince the patient, because the patients are used to listen also from us. Oh, okay, 7, you are not able, 6 or 5, do something. So they are confused from this if we are not clear-cut ever saying 7. Okay.
Thank you very much, Dr. Piga.